welcome to another episode of Home of Medicine podcast. You're joining me, Dr. Ben Lovell, and...
Hello, me, Dr. a.Burbridge.
Amy, I think today you're going to give me a case, and my pen is poised over my paper.
Excellent. Thank you, Ben. So, I've got a 24-year-old male, and he presents to the emergency department. And he comes in with a 3-week history of fever, exhaustion, and just feeling run down. He works very hard as a plumber, and it's really, really long hours. And he feels that he's just been working hard for a very long time and has just got to the point where he's just completely and utterly exhausted. He's not eating properly. He's not doing any exercise. He's not getting outdoors at all. So he's lost a little bit of weight. He's unsure of how much, but, his clothes feel a little bit looser. He's not very big anyway, but he feels like he's lost a little bit of weight. Really, that's all he tells me. He is a really interesting character. He's fantastic to be in a room with. He's one of these people who just exudes joy. And it's really nice to take a history from him. Really nice to chat to him. However, whenever you ask him a question about why he's come into hospital or a history, he starts to talk on a tangent about something else. So he's like, oh, have you seen what's going on outside? The weather's glorious. Or have you ever thought about what did you watch on TV last night? And I'm like, really interesting. However, we really need to ask a few more questions about why you've come to hospital. But he just keeps going off on a tangent. So to be honest, I'm probably in the room with him for about 25 minutes. And all I've really managed to get is that he's had a bit of a fever for a few weeks. He feels really, really exhausted, although he doesn't look it. And he's lost some weight. He's been working incredibly hard as a plumber, and he likes watching lots of really interesting things on telly. So, any thoughts?
Yes, I have. I mean, I'm thinking man flu. Sorry, I meant to say a viral infection in a man. It happens to be a man. What do you mean by fever? Because patients say fever, but do you mean he felt hot, or was he measuring his temperature and he was actually recording high temperatures?
He wasn't measuring his temperature at all. He just said that he felt hot. Okay. And he felt hot on and off for a few weeks, but no night sweats.
Okay, so that's important because you said run down, exhausted, working hard. I mean, that all goes together. You don't have to be organically unwell to experience those symptoms. If you were having a fever, that would change matters a little bit, because it doesn't matter how stressed you get, you should never be able to spike your own fever. But if he says you're just feeling hot, then exhaustion, run down, and working very hard, losing a little bit of weight. I am thinking, first of all, is he just burning the candle at both ends, and this is just a natural outcome of what's going on in his life. In terms of organic problems, feeling hot, tired, run down, it could be any system. It could be he's anemic, it could be his thyroid's gone wonky, it could be any other metabolic result, it could abnormality like low sodium or high calcium. I mean, you can go through all of them. It could be a new presentation of a malignancy, it could be a new presentation of heart failure, it could be a new presentation of a chronic respiratory disease like COPD. So I'm nowhere forward in diagnoses, but my initial formulation is this might not be a biological, an organic problem, but let's explore it.
Yeah, absolutely. Yeah, and I was thinking along the same lines. I came out of the room and wrote down what I'd found out, and I've literally found out not a lot. I had actually found out a huge amount about him, about his type of personality, about what he likes to do in his spare time, which is actually also really important. And while I was finding that information, I was observing him. So I was observing him. Although he said he felt very fatigued and tired, he was very upbeat. He was moving around the room very well. If anything, he was, I guess, a bit like me, a bit more on the hyperactive side of things. So he didn't look unwell and fatigued. So I wasn't too concerned. However, I did really need to get some more information from him. So I came out and went back in and I said, right, I'm going to ask you some questions, just some yes, no answers, please. And try to do that closed questioning, which I never do. But sometimes when the time is right, you have to do that. So when I delve down a little bit more, do you have any diarrhea? No. Any constipation? No. Any night sweats? No. Headache? Rash? No. Sore throat? No. Any appetite problems? He said he hadn't been eating as much because he was very busy. But apart from that, nothing really. He had no itchy skin, no chest pain, no breathing problems. General systematic review was normal. I found nothing apart from fever, tiredness, and this weight loss. Very difficult to quantify how much weight loss. He wasn't sure, just close heart bagging. Past medical history of note. 4 years prior to this admission, he'd had an appendicectomy and he'd gone into hospital with some abdominal pain. He ended up with an emergency laparotomy where they found a necrotizing appendix. And he said that some of his bowel had died as well. And I took that to mean small bowel ischemia. That had been treated at the time and no further problems from that at all. No other significant past medical history of note. He wasn't on any medication. He was a smoker, quite a heavy smoker, 20 to 30 cigarettes a day with some occasional cannabis usage as well. And he worked as a plumber, long hours as a plumber, which involved working weekends. He played a little bit of football for the local team, didn't have a partner. He was sexually active with different people, but didn't have a partner, and he wasn't using any protection when he was having sex. Didn't use any other drugs apart from cannabis. And that was all we managed to get out of him. Anything else you'd like to know?
You say he's 24.
Yeah.
Okay, so a young guy. I think he's bought himself a set of bloods.
Okay.
But I'm still not pinning it on a single system here.
Yeah.
Body at all. I mean, you could make an argument for every single system from neurology to gastroenterology. What could be going on here to drive his symptoms? So I think an FBC use and ease would be a nice place to start,
Okay.
and a thyroid function as well. Tired all the time and losing weight. I mean, if someone's hypothyroid, they tend to be tired all the time and gain the weight. But and yeah, I think it's still worth screening him for thyroid disease. Anything else? We better examine him as well, Amy, haven't we? Before we sort of throw blood tests at the wall, and just make sure there's no masses, lumps, bumps, no lymph nodes, which might herald some unpleasant hematological diagnosis.
Okay, so absolutely. So on examination, his temperature was 39.
Ooh. Okay.
Blood pressure's 90 over 50.
Right.
Interesting.
No,
Yeah.
but young people, you can run lower blood pressures. But you say did you say he was a normal weight or slightly underweight now?
Yeah. He was a normal weight. I mean, he wasn't certainly overweight or underweight. He was around 70 kilos. His heart rate was 100 beats per minute.
Yep.
His respiratory rate was 16.
1-6. Okay.
And chest examination was normal. Chest was clear.
Yep.
Heart sounds normal. Abdomen soft and non-tender. I could just see a scar from the previous laparotomy, and it was a large laparotomy scar rather than the appendicectomy scar. Nothing else of note. No rashes, no pedal edema, nothing apart from this temperature.
Okay.
No lymph nodes, cervical lymph nodes picked up.
Okay. Not much data yielded there, aside from the fact he's febrile and slightly borderline tachycardic, 100, but slightly hypotensive as well. Okie dokie. All right. I want some blood tests, please.
Okay, so what would you like?
FBC first.
Okay, so his white cell count, 29.
High.
Neutrophil count, 27.
High, okay.
Hemoglobin, 80.
Low.
Use and ease, normal.
Yeah, use and ease, please.
Urea, 6.
Normal.
Creatinine, 90.
Probably normal for his age.
Yeah.
Okay.
Normal, yeah. Sodium was 132.
Slightly under normal range.
Yeah, and potassium was 4.6.
That's normal. Okie dokie. I'd like a CRP if you have one.
400.
Hello. Right. Now we're talking. Right. Okay. Inflammation. This is an inflamed human being. They've got a fever and a very high CRP. Inflammation can be infective or non-infective, and infections can be bacterial or viral. They can be fungal. They're not an immunocompetent people, who are febrile, really. So we've opened the door to some different pathologies there. We've talked about a case similar I had previously in one of our previous episodes about these bizarrely high CRPs and white cell counts, and
Yes, we have.
whether you admit, and if so, whether you do antibiotics. And I think we agreed that we'd like to be quite brave and hold hard off antibiotics, but culture everything we can get our mitts on. So this is someone who desperately needs blood cultures, and urine cultures would be nice as well. And chest X-ray as part of sort of my basic septic screen. And in a minute, I'm going to tell you about whether I'd admit him or not.
Okay. Okay. So you're absolutely right. And that's what was happened. So his urine screen was normal. His blood cultures were negative. Okay. So we had 2 sets of blood cultures done, and they were both negative. You mentioned chest X-ray, which was clear. Nothing on that at all.
Okay. So in this particular case, what I would do now is I'd hold off antibiotics, even if it's febrile with a 3-digit CRP. The reason being, I don't have a source to treat. There's no signs of a bacterial infection, clinically speaking, but only do that with the proviso that I get to see him a lot over the next few hours and days to make sure nothing has changed.
Yeah.
So either this is someone who I admit to until the diagnosis declares itself, or I see daily in SDEC if he looks really well, and it sounds like he does, just to see when finally the results become clear to me. And they always do make themselves clear eventually. I've talked a lot about infection. Is there anything else which could be doing this? Neutrophilia, CRP, an inflammatory state. I mean, there are hematological diagnoses. Look at his anemia. He's not pancytopenic. Sometimes you can get acute pancytopenia with a nasty infection, but his platelets are normal. So it's just open this down. What's his MCV normal?
MCV is 84.
So it's a normocytic anemia. And his urea is normal. So he's not someone who's also having a GI bleed. And he doesn't say there's any hematemesis or there's no coffee ground.
Denies anything like that.
But he's not losing hemoglobin. Is he no longer making hemoglobin? Or has he got a normocytic anemia because he's got a chronic inflammatory state? You said the history was only 3 weeks old. So that doesn't quite fit. So I'm talking about infectious problems. We're talking about hematological problems, such as a new diagnosis of a hematological malignancy, which could have knocked off his bone marrow, so he stops making hemoglobin. It causes a profound inflammatory response, makes him lose weight and feel hot. He's not having night sweats he's getting, or just hot all the time?
No night sweats. He denies night sweats.
The hematological problems up there, maybe a blood film at this point might be useful, that any abnormal cell morphology. And other things I do when I'm working someone up for hematological diagnosis is things like LDH, globins, thinking about his hemoglobin. Let's get a B12 and a folate as well, and iron studies, and any other sort of inflammatory rheumatological flavored conditions that could do this. Now, you've already gave me adult onset Still's disease recently, but I don't think
it's definitely not that.
But of course, that doesn't work in your actual clinical life, does it?
No, could you imagine if you saw that too? Yeah.
So that's where I am right now.
I'll give you some of the blood tests then that you wanted. So we had a blood film, which showed toxic granulation, suggestive of infection.
Okay.
He had an LDH, which was normal.
Yep.
What else did you want to know?
Hematinics were okay.
B12 and folate was normal. His haptoglobin was normal. At the time, we diagnosed infection and gave him IV antibiotics because I guess the high temperature, the high white cell count, the neutrophilia, the CRP, it was sort of infection staring you in the face, although it might not be infection. But now we had the blood film, which showed toxic granulation. We gave broad spectrum antibiotics.
And you admitted him?
We admitted him. We admitted him. Whether that was the right thing to do or the wrong thing to do, who knows? But we've talked about high CRPs before, haven't we? To admit or not to admit. When I saw this patient, I was a registrar, so I was still in training. So my risk a sort of aversion. I didn't like taking as many risks as maybe I'm prepared to now, just because I've got experience under my belt and I feel a little bit more confident in my sort of diagnostic skills potentially. However, these antibiotics didn't work.
What do you mean?
So he still had a temperature.
Okay.
So, although we gave him the antibiotics, he had 24, 48 hours, but his temperature remained high at 39. His
Uh-huh.
blood pressure remained about 90 systolic. So, we gave him fluids, antibiotics. Nothing seemed to change. The white cell count remained high. We were like, what is going on? And then he said to us, well, actually, I ache now and my body's starting to ache. So my joints, my wrists, my knees, in fact, I ache all over. Like muscular aches. I promise you it's not Still's disease. Muscular aches. The type of description when you have the flu, actually. That whole body ache. But he's particularly said that his wrists and his fingers are really sore. However, he was a plumber and he used his hands a lot and he was working a lot with cold water, he said. So, and actually on reflection, this ache and pains in his hands have been going on for a lot longer than, a couple of days, a couple of weeks. So we're like, well, that's probably is just due to his job, actually. But we were still
Were
stuck.
the joints swollen, or were they just painful? He didn't have like a arthritis, no?
They were a little bit swollen at the second and third metacarpophalangeal joint, but nothing significant. You wouldn't look at his hands and go, whoa, they've got active synovitis, to be honest. You would never think that. And they
Okay.
weren't hot either.
Because you can get like a reactive polyarthritis, can't you, in the context of
Yeah.
acute infection? I saw it only a
Yeah.
few weeks ago.
Yeah.
A young woman, and I thought that she was going to get a new diagnosis of rheumatoid, but the rheumatology team came and said this is going to be a reactive event. It'll settle down with time.
Yeah.
And maybe I would think about that in his particular case if it were me at the time.
Mm-hmm. Yeah. And that's certainly something that we were thinking of is, could this be a reactive arthritis? Now, just go back a few steps. Let's go back to blood tests. So there are a group of tests that we haven't done that may be quite helpful in this case.
Well, we haven't got here on my form, we haven't got a bone profile and thyroid or liver function. What else are we lacking over here? I'm assuming his serum glucose was okay.
Serum glucose is fine, yeah. Yeah. But I do have his alkaline phosphatase, which is 270. And the normal limit is 35 to 120 at the time of the blood test that I did it. So it's high. So it has a high alk phos. Liver function, the rest of his liver function and bone were completely normal and calcium was normal.
High alk phos is so non-specific.
Yeah, it is.
I feel like everybody has an alk phos if it comes to the medical take. And I never know where to really park that except to say, oh, it'll go down. And we do it sometimes with Amoxiclav, actually. That often pushes people out phos up a little bit. But
it doesn't really tell you anything, does it?
No, it tells me nothing. Tells me nothing at all.
Okay. Yeah. However, what about, do you want to do any more infective type blood tests?
ESR.
Ooh, ESR. So at the time, we were doing plasma viscosity.
Oh, wow.
I know, it's retro. And that was 2.16, which was high. So we would correlate that with a high ESR. So this would suggest that the inflammation had been going on for longer than a couple of days.
And this would probably I was going to say procalcitonin, but we already think it. Whether it's
we don't do those, to be honest. I've never requested that blood test in 19 years, just because we don't have it. Never worked.
Yes, so inflammatory marker. Sorry, did you say what other inflammatory markers we hadn't done yet? So other hot markers of infection, inflammation. I guess what we haven't talked about is the only thing is ferritin, but I'm sure you're not going to go down a Still's road again. So
no, that would be really. So what about specific infections? Do you want to look for any specific ones?
Well, the context of the ALP being raised, that's deranged liver function. Should we do a full liver screen? So hepatitis A, B, C. Why not do D and E? And also CMV and EBV. I mean, these are common infections that go around in younger populations, but EBV and CMV, they tend to present as the flu with really bad lymphadenopathy, sometimes a bit of splenomegaly as well, and often with skin changes, rashes, but they can derange your renal function quite a lot. I've never seen them cause toxic degranulation of a white cell count before.
Mm.
Actually, I don't think I've ever seen it with a viral infection before, but
Mm.
yes, hepatitis. He hasn't traveled anywhere.
No,
No,
no travel.
and of course, you've given me lots of information about his unprotected sex. So let's do an HIV test and
Yes.
a sexual health screen as well.
Yep. Okay, so hepatitis serology was all negative.
Okay.
HIV was negative.
Yeah.
And at this point, we were a little bit stuck. However, what we do have in front of us is this unwell gentleman, although he looks very well still look very, very well throughout all of this. We're still bouncing around the ward. You get these patients who are chatting to the other patients, who's off, going off for cigarettes because he was a very heavy smoker. So he's still wandering off the ward, chatting to everybody. We were reassured, by the way, at this point that he didn't have a communicative disease, for example. He wasn't spreading it around. So he did look really well, and we just couldn't get to grips with it. So he had a low hemoglobin. And somebody suggested let's do a OGD. Although he had denied any, you're putting a face at me, and we did it, and he had a reactive gastritis. So nothing, there was nothing there to suggest the cause of his anemia, and it wasn't an iron deficiency anemia anyway.
Yeah.
He had an echo, which was normal because somebody had mentioned, could this be subacute bacterial endocarditis? He's got a fever, he's got some weight loss, he's got some joint pain. So could this be SBE? However, he had no murmurs, he had no infarctions, Snellfold infarcts, no Janeway lesions, no Osler's nodes. So, however, I don't think I've ever seen one of those. Maybe once. However, he didn't have anything like that, but his echo was completely normal. He didn't have a transesophageal echo because we didn't feel that endocarditis was a high chance anyway, so we didn't go down that route. However, we did still have this man. We hadn't found an infection, and I guess we're now going down the pyrexia of unknown origin route. What are your thoughts?
So I know that if someone's had a PUO, pyrexia of unknown origin, I think the first line test recommended is a PET scan, a PET CT scan, which is something that hospitals can do now. But when I was a reg, we didn't get many PET scans.
No.
Often we do a CT, chest abdomen pelvis, to go on an infection hunt, because sometimes CRP can hide in the belly, in the forms of collections and abscesses and things like that, and not necessarily presenting it as with abdo pain even. So we would do that as a first line. But nowadays we do have pretty good access to PET CT scans, and that can show up infection. It can light up like a Christmas tree and also give you a sort. So that would be the next step, I suppose, for a PUO.
Yeah. Have you got a structure, like a diagnostic surgical sieve that you work through when you have somebody with a pyrexia of unknown origin?
I do not have a formal schema, no, but I'm happy to share yours.
Well, no, I was just wondering whether you did. So the consultant of this case at the time, who was this incredible woman called Dr. Shirley Rigby.
And oh my gosh, I know her. I know her. I met her in Latvia at the European School of Internal Medicine. She used to go to that.
Yes. Yeah. So she was my consultant at the time when I was managing this case. And I actually still see her now, and we still reflect on this case because it was that, you see a case and it really stands out in your mind. And for both of us, this case does. So she told me this schema that I know I've mentioned many times before, but I owe it all down to Dr. Rigby. V is for vascular. So is there a vascular cause of the PUO? I is for infection. And if it is infection, bacterial, fungal, viral, parasitic. T is for trauma. A is autoimmune. M, metabolic. The next I is iatrogenic. Is there something we've done in the hospital to this gentleman that's caused this? N is neoplastic, and D is drugs. I love it. I always remember it. And it always helps me focus because I have a tendency to go off focus sometimes. So if we have this schema to work through for this gentleman and his PUO, which we did do with him, I'd love to look at his notes actually and actually see what because it was all on paper, see actually what we wrote way back when. So, any vascular causes that you could be thinking in this gentleman?
Well, vasculitis, I guess that he has some kind of vasculitic process, but I keep going back to the toxic granulation of white cells and thinking that doesn't fit.
Okay. Eye infection we've talked about, haven't we?
Yeah.
Yeah, trauma, he hasn't really had any
No.
that would anything autoimmune.
Yes, you do get a family of autoimmune diseases, but which can cause recurrent fevers,
Mhm.
such as familial FMF, familiar Mediterranean fever. But he hasn't got abdominal pain. Recurrent serositis and recurrent fevers. You can get high fever when you get a really bad sort of lupus crisis as well, can't you? But usually in the constellation of many, many other multi-organ signs and symptoms and rashes, and he had the joints, didn't he? The
He did.
joint.
However, we did do a double-stranded DNA, which was negative. We did a rheumatoid factor, which was negative. We checked lupus anticoagulant, which was negative.
Yeah.
And we did these cryoglobulins as well, which were not detected. And we
Right.
also did a serum angiotensin converting enzyme, which was negative as well. Okay, so we also did a serum ANA and a serum ANCA. Anybody who knows me, ANCA is my favourite test of all, and they were both negative as well.
I do have to ask, why is that your favorite test of all? That's quite a strange statement.
It's not really, it's not. It's just that when I was a rheumatology trainee, for some reason, everybody used to wind me up because I talked about ANCA a lot. And I think I did a lot of presentations on ANCA
Mm.
as a room trainee. And everybody would be like, "We check the ANCA, Amy." And I'd be like, "I don't check it on every patient who comes in." So, and when I first left rheumatology and went into acute medicine, it was really hard for me to get out of that room mindset. So I would do inappropriate anchors because I was very heavily biased towards rheumatological conditions. Didn't last very long when I was in acute medicine for a while, and I think that's why. But that still follows me around whenever I see somebody I used to train with. They still ask me about my anchor session.
The anchor woman.
The anchor woman. Okay, so metabolic conditions. Any thoughts?
Metabolic conditions which would cause fever, anemia, raise CRP, white cell count. I don't think so. Am I missing something?
No,
No.
no, I don't think so. Eyes iatrogenic. Have we done anything to him?
No, because
No.
before we've even got your mitts on him, so it can't be that.
N is neoplastic. So
Okay.
could this be a malignant process? Well, yes, it could. You've already mentioned hematological, and you said that you'd like to do a CT, so hopefully that may help us down that route.
Yeah.
These drugs. So anything he's been taking or anything that we've given him?
He didn't have a big eosinophilia, did he?
No. What are
No.
you thinking?
Stress.
Stress.
Yeah.
Stress.
I just want to think of drug reactions which cause like a
Yeah.
systemic.
Ooh, okay, nice.
That's the only one I've got. And well, there's others, but they don't apply here, like Stephen Johnson syndrome and all that sort of thing. But that's
No,
not the case. So no, I
no.
can't think of a drug.
Okay, so I'm going to give you the result of the CT abdomen. So at the time, we didn't have PET scans and it wasn't something that was accessible. So his CT abdomen showed small volume lymphadenopathy.
Right.
And he also had a bone marrow, trephoid and aspirate, from the hematological perspective. And that was normal. So we've sort of ruled out the leukemia, lymphomas. CT abdomen hasn't really showed us much apart from a small volume lymphadenopathy.
Right. Now, on the CT scan, did you said there was some small lymphadenopathy?
Yeah, small volume lymphadenopathy scattered throughout the abdomen.
Right. Doesn't sound like there's much of a target for a biopsy then.
No, no, not at the time.
So we
Absolutely
probably
not.
diagnosis on that. Gosh,
So,
I'm
what would you do? I know what I did. I
phone a
spoke to
friend.
Dr. Shirley Whitby. I phoned a friend. Yeah, yeah. So we sat down with all of the information that we had and went way back to basics and retook the history, re-examined, went through every single test that we had in front of us. And she said, "Should I give? Do you want me to give you the diagnosis? Do you want to? What do
Yeah.
you think?"
Yes. I was going to say, give me the first letter. I want to guess the rest. No, you please do.
Okay,
Yeah.
well, I'll give you a provisional. Okay, so She said, this fits a vasculitic process, which is what you said way back when we went through our surgical sieve of vitamin D. So we'd sat down and we'd gone through this process together and we'd ruled in and ruled out different diagnoses. And she said, oh, this could be a vasculitic process.
Right.
ESR, CRP, weight loss, young guy, joint pains, doesn't fit anything really. So started prednisolone, 30 milligrams daily.
Okay.
And his symptoms responded very quickly. And when his dose was reduced, he relapsed.
And at this point, antibiotics had been stopped as
Antibiotics had been stopped.
an infection had been very satisfactorily ruled out, because obviously you wouldn't start immunosuppressing someone if you thought there was
no. So this was around day 4, day 5 of his admission. And this was with all of the tests that I've given to you that were all negative.
Mm.
So we couldn't find any infection, chest x-ray, bone marrow, CT abdomen, there was no collection. You know, we were very confident that this wasn't an infection. So let's go for vasculitis, which can present with pyrexia of unknown origin, weight loss. However, we did one more test that confirmed the diagnosis.
And this, was it an antibody test?
No.
Although I don't know. Go on, tell me.
Okay, although it would be. No, it wasn't an antibody test. We've already had an ANCA negative and an ANA negative. So Dr. Rigby said to me, so let's do a CT angiogram.
Right.
Okay. And the CT angiogram showed tight stenosis of the left renal artery and macroaneurysms of the hepatic artery. In the liver, there were multiple areas of arterial portal shunting which were present.
Right.
Consistent with a diagnosis of?
It is a large vessel vasculitis then. It sounds like the vessels are large.
Medium to large vessel. Mm-hmm.
Oh gosh, medium to large vessel vasculitides. What do I remember about those? Henoch-Schönlein, he's got no skin involvement. Kawasaki is children.
Focus on the medium vessel vasculitides, of which there is only one normally.
Oh, go on, tell me. I'm embarrassing myself. I don't know.
No, you're not. No, It's polyarteritis nodosum.
No, it can't be.
Why?
Because it doesn't fit my mental model.
Okay.
what polyarteritis nodosa present? Okay, teach me about it.
I'm interested what your diagnostic schema is then for polyarteritis nodosum.
Older adults. So
okay, yeah, right, yeah.
Association with Hep B, gut involvement. Well, he has. You've just told me he has. But like gut signs. Sometimes ulcers along the sites of vessels on the skin, cutaneous ulcers. They can get peripheral neuropathy, I think, with it. And that's all I got.
So you're right. However, things often don't present the way we want them to present, do they? And this was the case in this gentleman, in that he presented in a way that an experienced rheumatologist had seen before.
Yeah.
So she'd utilised her previous experience and exposure that she'd seen in vasculitis at different centres across the UK and went, I've seen this before. I know what this is. And we know when somebody says that, I've seen this before. Okay. And she said, this to me looks like polyarteritis nodosum, because that's what she'd seen before. I'd never seen it before. So I've got nothing to reflect on. So polyarteritis nodosum is a systemic condition. It's necrotizing vasculitis. So it's not just an inflammation of the vessels, it necrotizes them and they can die, and it's really, really nasty type of condition. What happens is the tunica intima proliferates and gets thicker and thicker and thicker. The vessels obviously get narrower. Because they get narrow, you can get ischemia and infarction, but also because the tunica intima proliferates, it becomes weaker. And because it becomes weaker, you develop these aneurysms, these outpouchings, which can be quite concerning. This can happen in the kidneys, in the skin, the immunological system, the cardiac system, and in the gut as well. As you said, it can be primary or secondary. Primary, one of those things. Secondary, Hep B and Hep C, which were negative in him. And occasionally it can happen in hairy cell leukemia. Men more than women. Men usually middle-aged to older men. And obviously he didn't fit that criteria, did he? He was a little bit younger than that. Patients often present with hypertension. That's often their first presenting complaint. Or they may have heart failure. So they may have some shortness of breath, some edema. It is a clinical diagnosis because the ANCA and the ANA are negative. Often you've ruled other things out. And this, I think, is the beauty of this case, is where Dr. Weber came in and went, I've seen this before. This fits what I've seen before. Interestingly, his past medical history, he'd had a necrotizing appendicitis and small bowel ischemia, which to her was the clue. She went, okay, it doesn't fit, but what was going on a few years ago? This could be PAN. And we treated him with prednisolone and cyclophosphamide, and his pyrexia settled, his synovitis settled, CRP rapidly reduced to normal, and went on to have a very, very good recovery.
I think I could have looked at that case for 100 years and never come up with that diagnosis.
Yeah.
It's funny because you can be as book smart and as brilliant at exams as you want, but unless you've seen a million patients to put inside your personal patient library, you can't necessarily link things together and pull it out based on a previous experience. And what we need to do then is create and revere an army of senior consultants who've been around the block a few times and have seen a few things, and then pass that along. And I guess that's sort of the apprenticeship model side of medicine training, isn't it? That occurs outside the classroom, that occurs at the patient bedside in clinical areas, and is a really viable way of passing along wisdom, phronesis. Now, who called it phronesis? It's probably Aristotle or someone, but one of the ancient Greeks. And phronesis is what we would call experiential wisdom, and you can only get it by seeing a lot.
Yeah.
And we kind of know that. We make training in this country to be a lot about, especially if you're a surgical trainee or you're doing procedural skills, about numbers. You've got to have a lot of numbers, and you've got to have your logbooks up to date. You've got to have seen a lot of stuff. And the reason for that is because we want you to have a lot of previous scenarios you can draw from when you're making a tricky diagnosis like this. And I never had this one in my library, but I do now.
Exactly. And I've never seen a case of polyarthritis nodosum since. However, it's there, and it really sticks out in my mind, even that we do still talk about it now. And I often wonder how he's doing. I think it shows the beauty, this case, of when you have an experienced physician who relies on the beauty of clinical signs, clinical acumen, history taking and examination, can get to that diagnosis without the fancy PET scans, without all of these scans, because she's seen it before, she's got that illness script, she's able to say, could this be this? Could this be that? And I think that's really magical. I think one of the things we've lost a little bit now is that apprenticeship model, in that we are very tick box orientated, we're very portfolio based, which I understand the reason for that. But I do sometimes think that apprenticeship model, she was my mentor for a year as a trainee, but also continued to mentor me and still does now. And that seems to have gone a little bit. And I do wonder whether that's just a consequence of the NHS now, to be honest. I'm not sure. But interesting case.
I remember my mentors very, very much. I'm still with them. So I think that is a very powerful learning paradigm, the apprentice and the trainer. Thank you so much for that case, Amy. I've got to say, I'll still be puzzling it over now, all these years later, but with me. So thank you for getting me over the finishing line with the diagnosis. We should call this episode of the podcast Ben Gets Stuck.
Okay. Yeah, I'm going to call it Ben Gets Stuck.
Come and help him out.
Yeah.
But there's loads of learning from that, both clinical and non-clinical. So I really appreciate hearing about that case today. And hopefully that's going to stick with me going forward. Maybe I'll make a diagnosis of PAM before I die or retire, whatever comes first. And thank you so much, Amy, for that lovely case today. It's been great to talk to you as per usual.
My pleasure.
Everyone listening, thank you so much. Please tell your friends, acquaintances, your grandparents, your cousins, anyone you've ever met about the podcast and how great it is. Please come and rate and review us. It means so much to us and it helps us grow the podcast even further. And watch out for further episodes. And I'll see you all next time. Bye.
Goodbye.
You've been listening to the Home of Medicine podcast, a podcast brought to you by the EFIM Academy in association with the European Federation of Internal Medicine, a leading organisation in internal medicine. Thanks for listening.